All right, good afternoon, everybody. We're going to go ahead and get started. Wanted to welcome everybody to the Ohio chapter of the American Academy of Pediatrics webinar on coding changes for 2021. Next slide, please. I'm Chris Peltier. I'm a pediatrician at Pediatric Associates of Mount Carmel. I'm also president-elect of the Ohio chapter, and I'm going to be the moderator for today's session. Next slide, please. We are going to, just for background noise, and since there's going to be probably close to 50 people by the time everybody logs on, we're going to ask that you stay muted. And if you have a question, please enter it in the chat box, and we will moderate the chat box and make sure that our presenters get the questions. If for some reason we don't get a chance to answer everybody's question, we will send out sort of a summary of questions to everybody. And I did also want to remind everybody that we are recording today's webinar, and we're going to share the recording and slides along with any question and answers that we get to in a follow-up email. Next slide, Kristen. So we have one simple objective today, and I say the word simple sort of in tongue in cheek, and I think those of you that have been looking at this already, and as we go on, you'll see that at times it's anything but simple, and that's really to increase provider knowledge regarding the upcoming coding changes that begin in 22 days, I believe, 23 days. Next slide, please. So our agenda over the next hour is to look at the implementation of the new 2021 Evaluate and Management Coding and Documentation changes. We're going to look at adoption of new adjusted 2021 E&M relative values and payments. Then we're also going to have an update on 2021 RVUs for vaccine administration codes and see where that stands as we head into the new year. Next slide, please. So before we begin, just some disclaimers. While our presenters today are very experienced and very knowledgeable, they are not certified coders, nor do they have any legal credentials. They do not work for either the AMA or the AAP, and that the information we're presenting today is the personal interpretation by today's presenters of it. Kristen, was I muted the entire time?
No, you weren't. We were hearing you well, just for one
Okay,
second.
great. So somehow I got muted. Sorry about that. So I'm going to restart the slide. So just some disclaimer that today's presenters, while very knowledgeable and experienced, are not certified coders, nor do they have any legal credentials. They do not work for either the AMA or the AAP, and the information that they are presented today is their interpretation of educational materials that is available in the public domain. Please keep in mind that there are nuances to coding, documentation, and audits that are evolving. This is a new area, new territory. We have not dealt with these codes. Obviously, payers have not dealt with these codes. And additionally, expert guidance continues to evolve. It is the legal responsibility of each practice and provider who sees patients to educate themselves to the fullest extent possible and choose the most appropriate code that represents the work which they performed. And I'll say it again, as our presenters will probably say, document, 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 because if you didn't document, it did not happen. Next slide, please. So a couple of things that we aren't going to be addressing today. We are not going to be separately discussing telehealth. We also will not be separately discussing areas in which there are no changes for the upcoming year. That means ill visits when combined with well visits, consultation codes, codes that are used in the emergency department, and hospital codes. Next slide, please. It's my pleasure to introduce our two panelists for the rest of the session. Dr. Michael Chamberlain is the managing partner in a 9-pediatrician, 3-office practice in Cincinnati at Pediatric Associates of Mount Carmel. He serves on the board of the Ohio Valley Primary Care Association, which is a clinically integrated physician association whose goal is to improve the care for all children in the greater Cincinnati area. He's been in practice for over 20 years, and he's currently a member of National AAP Payer Advocacy and Advisory Committee. John Price was in private practice for 18 years before becoming an urgent care attending at Nationwide Children's Hospital. He is co-chair of the Pediatric Care Council, which is the Ohio chapter's dialogue group between pediatricians and payers. Also, as the chair of National AAP's Committee on Child Health Financing, he is a member of the Payer Advocacy and Advisory Committee, along with Dr. Chamberlain. The goal of these committees is to prevent families and pediatricians from going broke when they try to get or provide excellent care for children. I'm going to turn it over to Dr. Price and remind him to unmute, and we'll begin.
Okay, thank you, Chris. My part of this is to talk about some specifics about the new changes in the documentation requirements for the purposes of coding and billing, whereas Mike's going to be talking about the payment issues that are connected with this. And I thought that it's important for us to take a pause and start off remembering the real reasons why we are documenting in the first place. And only one of them is for billing and coding purposes. Always, 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 our documentation, no matter what year we're talking about, need to be coherent enough to tell a story so that you can refer back to it later, or your partner can look at it to make sense of what was going on with the patient and what may need to be done in the future. Also, there continue to be the medical legal implications. Again, if it wasn't documented, it wasn't done. So if this year you felt it wise to document that your febrile patients had necks that were supple rather than stiff, it will still make sense to do this in 2021 and hereafter. Billing, however, is about getting payment for the value that you provide in your work, and that is what's being redefined. Next slide. And as you know, the note templates that exist on your electronic medical record or the cheat sheet checkoff boxes that you might use in paper documentation value certain things. And since 1992, they have valued how much of a history you take and how much of an exam you've done in various ways, sometimes awkward, in documenting that and enumerating that, as well as your medical decision making. Next slide. Yeah. And of course, as we've all experienced, there is a burden to all that. 75% of pediatricians say that among the ones that are experiencing what they're self-describing as burnout, 75% of them say that one of the reasons, if not a key reason, is the increased amount of paperwork, of documentation that they're doing. And of course, the more you're doing that, the longer your day is, and or the less time you're having in your face-to-face interaction with your patients. Next slide. And of course, this one is self-evident. In fact, there's even a medical legal risk that you might miss in reviewing an old record. You might miss something pertinent because previous notes are buried with extraneous things that keep being recapitulated on the social history, the family history, even if it's not pertinent to what's going on presently. So in 2021, changes are happening because the outgoing administration, as part of their ideological preference for deregulation, wanted to decrease paperwork, which helps us. Their Patients Over Paperwork program, which in pediatrics you might call kids over clicks or teens over typing, created this program, and they charged the AMA, which are the people who define and create CPT codes, to redefine in a way favorable for burdensome documentation, to redefine the E&M levels of service for our office codes. And obviously, the goal is to let you spend less time documenting in the hope that it will let you engage in more complex decision-making, more time-consuming things with patients. May work out for the patient, may mean less referrals to a specialist if you tackle yourself to do something you've been trained to do, and so on. Next slide. So these changes have real implications. On the right-hand column, you see there that The overall level of E&M service no longer has anything to do with how much history and physical you're doing. And your level of service is determined either by, and here the exact words are important. Total means total time spent by the provider on the patient. And important is the phrase on the day of the encounter. Or if you're not coding according to time, it'll be based entirely on your medical decision making. Next slide. As we've already alluded to, there still needs to be history and physical for the sake of having a coherent narrative for yourself, your partner, and for medical legal reasons. But your notes do not have to recapitulate history that's found in other charting. So if you've documented a telephone call you took last night when you were on night call, or something that came to you on a patient portal, as long as it's retrievable in case you're audited, or there has to be a legal review, as long as that exists somewhere, it doesn't have to be in your note that you're doing for that day's encounter. And you can do with that information what you will, whatever's more convenient for you. But it's not driven by billing and coding. Next slide. And so if you're designing a new note, a new template, it has to be able to capture either of those two things, total time or the elements of medical decision making. Now, your H&P is what's appropriate, but your new templates have to be able to encounter these two new essentials. Next slide. This slide is here. Even though the left side is familiar, everything on medical decision making, the mantra is problems, data, risk, problems, data, risk. On the right-hand side, what's new is that part there at the bottom, that now if you're coding according to time, time now includes your non-face-to-face time. So not just performing your exam, but also, and your discussion with the family, but also reviewing the records that day, ordering tests, documenting your visit, and coordinating care with somebody else. All of that counts. Next slide. Okay, most all of us are already familiar with using a medical decision-making chart of some kind. This is the new 2021 medical decision-making chart. And for the sake of time, rather than going through every single element of it, I want to dwell on the things that might be ill-defined otherwise, or which might be new. So I'm going to start right off having a look at that 99202 or 212 row, where we're talking about that first column on problems. Again, everything is problems, data, risk, problems, data, risk. Under problems, you have to be able to enumerate up to 2. Beyond that, no further point. And then what are you counting? Well, one thing to know is that a problem is not a diagnosis. As you know, not all encounters lead to a definitive diagnosis. A problem counts if you're addressing it, meaning that you're evaluating it or treating it, even if it's to say, hey, this skin lesion is normal, or the circ site looks okay. You've addressed it. A problem doesn't have to be a diagnosis. It can be a concern, a finding, a symptom, a sign. Any of those count. You just have to be able to say what it was by the time you're getting to your assessment and plan. And on this slide, if you move over to data, here is to me, the most important new thing. When you go down to that first row, left to right, 9213, the amount of data is not minimal, but it's limited if you have either of those two categories. And for me, the obvious, most important change is category 2, assessment requiring an independent historian. And seriously, the AMA means that an independent historian is anyone that can contribute to the history that's not the patient, so not the child. So every visit you have where any of the history is contributed by the parent, Maybe they're giving the history, maybe they're correcting what the teenager is telling you. They are an independent historian, and that means that for none of those visits will the level of data ever be minimal. At the very least, it's going to be that category 2, and that gets you at least a limited. Now, when you come down to tests and documentations, choose to do that instead. I don't know why you would for 213, but if say, for instance, you have an unaccompanied teenager, then to get to that limited level, you have to be looking at 2 out of those 3 itemized things, which is a review of a prior note from a unique source. And a unique source is somebody other than you or people of your specialty in your group. So a unique source is somebody who maybe is in your group practice, but not a general pediatrician. They're not in your specialty, or it could be from any outside entity. Now, trick is, no matter how extensive the records are from your outside source, they only count as one source. So a zillion lab tests, from the rheumatologist, if you're reviewing those, well, you've looked at one unique source. Second thing, review of the result of each unique test or ordering a test. A unique test is something that has a CPT code. Now, new guidance we got just this week, which kind of disturbed me during medication days, was that AMA is defining a test that's countable for medical decision-making as a test not done in your office. They have decided that billing for a test with a CPT code in your office, you're already getting paid for it. And so they're deciding that ordering that test or reviewing the result of it can't be used to elevate your level of medical decision making. Now, I agree with you. You're probably saying, hey, the CPT code for the CBC that I'm doing or the rapid strep that I'm doing doesn't include any value for physician work. Therefore, it would seem that simple logic is opposed to this, but yet that's the way it is. So unless and until the AMA changes their guidance, reviewing and counting tests have to be external tests that maybe you've ordered and sent out, to the lab across the street or somewhere else in town, but not if you're billing that CPT code. Okay, next slide. It's busy, but as I said, I'm promising to stick with only the things that are not self-definable or new. And so I'm going to draw your attention to the problem column, where right now you're seeing moderate and high in that column. And I'm going to point out that chronic illnesses are defined as an illness or condition that's expected to last a year or more. But what I'm going to point out to you is under that 2 or more stable chronic illnesses, it's worthwhile to talk about what's stable and what isn't. Because you'll notice that when you go down from moderate to high and you look at chronic illnesses, a stable chronic illness is moderate, but a chronic illness with exacerbation or progression is high. Well, here's the thing that's not self-evident. A chronic illness where the patient is not meeting the treatment goals is not stable. So if you're managing somebody's hypertension or diabetes and you're treating it, but they're not meeting that treatment goal, that's not stable because it's assumed that failing to meet the treatment goal for a chronic illness is going to lead to some morbidity, or mortality. So that word stable is really shorthand for something that is a more complicated phrase, really. Stable meaning stable and meeting treatment goals. Yeah, in that column of problems, we have, earlier the previous slide, which I'm not going to have you go back to, talked about a self-limited or minor problem as being at a low level. that's something that's expected to basically resolve without treatment. It's transient, no risk of morbidity or mortality. Now, when we're talking about acute illnesses, though, an acute illness, say from that previous slide, an acute uncomplicated illness is an illness that you may need to treat, an ACE-RAP or Tylenol, but it nonetheless is expected to resolve without appreciable risk. And however, an acute illness with systemic symptoms is something that is more than just an illness with a fever. The examples that the AMA gives are things like pneumonia or pyelonephritis, an acute complicated injury, an injury that involves several body areas, for instance. It's a higher level of thing. Now, later on in these slides, you're going to see some clinical examples. I think the AAP, which will be the slides following these, will mention, for instance, say otitis media with fever, whereas they might put viral pharyngitis at a lower level. I think and call that a acute uncomplicated illness. I'm assuming that the difference is that strep with fever or otitis with fever has some possible morbidity or mortality risk if untreated. So if not for you, and therefore they're counting that as more like an acute illness with some systemic symptoms and at a higher level of risk as well. Okay, let's move over a column there to the, I'm sorry, not that's back that same slide, but now the middle column about what makes moderate and extensive levels of data. And now here we have different categories. The new categories introduced that weren't in those previous levels are category 2, independent interpretation of a test. That is a test that is already whose interpretation is already being built by somebody else. The cardiologist who's reading the EKG, the radiologist that's reading the X-ray. If you are making your own interpretation of that X-ray, then you can choose to say, hey, I'm independently interpreting it. Now, you might feel obliged to do it if if the radiologist didn't say, hey, what angle is that fracture, so that you can decide whether they need the orthopedist or they need something to, to decide, hey, the urgent care for a cast or the emergency room for a reduction. That would be an independent interpretation if the radiologist didn't help you on that one. Or if you always need to see, do I really think that this chest X-ray is a pneumonia, regardless of what the radiologist said? You have to indicate that in your note. Category 3, discuss, and this is important, discussion of management or test interpretation. That is discussion with some other professional about the management of the patient. It doesn't have to be a doctor. It might be the radiologist, about your X-ray interpretation where you decide to converse with them, but it might be a teacher, it might be a social worker. It's not a parent or a neighbor, it's a professional. So all of those things count. And as you see in that moderate category, 2 and 3, those elevate your possible coding. When you get to category 1, tests or documents or independent historians, now you see the independent historian, the parent who's contributing to the history, is one of those data points. And that leaves you needing to get only 2 others. Again, an external source of a note, a test that was done external to your office, whether you're reviewing it or ordering it. There you go. And that bottom extensive definition needs at least 2 out of those 3 categories. Now, moving to the right, risk. Here we have something new, and that applies to us in peds a lot. Look at those examples. And by the way, the AMA goes out of its way to say these are only examples, these clinical examples. They always are in favor of autonomy of the physician. So they claim that physicians they know the risks, and so they can assign the risks. Payers probably don't feel that way, but the AMA does. But anyway, they're now giving an example of look at that last one in the moderate column. A diagnosis or treatment significantly limited or impacted by a social determinant of health. So if in that visit, it's relevant to your diagnosis or management. Say it's either of those that slowed down because the parent has a literacy problem, or there's food insecurity or home insecurity, then that elevates your level of risk. It doesn't elevate it that much if you see it's on the same par as prescription drug management. So you get the same level of risk if you're writing a prescription for something, right? I point out that last part because I know that when the 21st Century Cures Act kicks in and your notes will be transparent to a family, you may decide that for parent relations, you may not be wanting to draw the attention in your notes to the patient's problem with literacy, or maybe they have a problem with your talking about their food or home insecurity. So you may choose to say, hey, I'm leaving well enough alone with my prescription for the amoxicillin that I'm writing here. I don't necessarily need to document that. You know, again, always your choice. And so there we are on that. The other things are pretty much self-explanatory, I think. Next slide. These are busy slides, and I'm not going to go through them. They are going to be in the slide deck that you get. But these are not from the AMA. These are from the AAP, and they're useful because they point out some of the things I have about the categorization of illnesses, stable, complicated, uncomplicated, in that big middle column. But over to the right, they're giving you clinical examples of what they think qualify as typical types of visits that would result in assignment of, you know, your 99212 or 13 or 14 or 15. So that's why I'm incorporating these slides as a reference to you. Next slide. More of the same. Next slide. Oh, and again, by the way, the definition of those were helpful because they talk about you know, qualified professionals you might be discussing management and care with. And continue on here with definitions. Next slide. Okay. One file here for us to look at these, and because I want to make sure Dr. Chamberlain has all of his time, I'm just going to go through a very simple example. The rest are in your slides. Next slide. Okay. When my sister went to the pediatrician in 1981, when I got to see her medical records, I saw this line, leftotitis, amoxicillin. In 1981, that was an encounter that got billed and paid. Next slide. As you can tell, we're bringing up documentation, rebuilding it from scratch. So we're going to take this visit now and look at it presently. Next slide. Okay, we're analyzing that level of documentation for 2020 E&M coding. And there you see the way it would be analyzed. The CPT police have already been notified. Step away from the chart, because this is basically uncodable. And bad things would happen to you if you tried to submit this as documentation. Next slide. Next one after that. Now we're coming up to next year. Okay, now it says left TM red, bulging, left otitis media, amoxicillin. Okay, we added medically appropriate physical finding. Coding it would say we had one self-limited problem. You might even argue that it's not self-limited, that it's an acute uncomplicated illness. But let's say, sake of argument, it's level 2. Amount of data is level 2 because you're not indicating any outside data at all. And moderate, level 4, because you're writing a prescription. Highest 2 levels out of the mantra of problem, data, risk. Highest 2 levels are level 2 or above, 99212. But next slide. Okay, another little detail. Next slide after that. Okay, Now our documentation says 4 years old. Mother says earache. Left TM red, bulging. Left otitis media, amoxicillin. Well, now we've added some history to the physical finding. Mother has been named as an informant. So now maybe the problem is still minimal if you choose to regard it as minimal, but now you have an independent historian. So your data is limited, level 3, gone up 1, and your prescription drug is still level 4. So your highest 2 levels are now level 3 or above. So it's now become a 99213. So next slide, Kristen. Your EMR can take the templates you have and streamline them. The next several slides I'm not even going to go into. They're examples of a rather lengthy electronic medical record encounter note for a sprained ankle, and how the old and new would look alongside each other. And as you'll be able to tell, a lot of things have been stripped out. Physical, our family history, social history, and so on. So with that, opportunity to streamline that you can view, I will turn things back over to either to Chris or to Mike Chamberlain, who can talk about payment.
Yep, I think we're going to let Dr. Chamberlain present.
Okay.
All right, thank you. Can you hear me okay?
Jump ahead to him.
Yeah, so jump ahead to, looks like slide 46. All right, thanks, John, for that very detailed explanation of the new rules. I wanted to mention, just in follow-up to that, there is a tool that's been created. Chip Hart from PCC created this as a spreadsheet and now has put it on a website free for anyone to use. It is an MDM calculator. You decide what your problem, data, and risk is, and it will tell you what code you qualify for. One thing I wanted to mention, that I think the independent historian is a very important thing to document. If you have an independent historian and you recommend an over-the-counter medicine, you automatically have a 99213. But we have to make sure we have good documentation of that. All right. So this is free for anyone to use, so I think it's a good tool, so you can take a look at it and see if it meets your needs. Next slide, please. My job today is to talk about the changes to the relative value units for the new office visit codes and how they may affect us. First of all, a relative value unit, or RVU, is a measure of the value of the CPT code, and these are calculated by or suggested by the AMA and agreed to by CMS. There are different components of an RVU. There are actually 3 different components. There's a work RVU, physician work RVU, the practice expense RVU, and a malpractice RVU. Next slide, please. The work RVUs for the office visit codes are changing for 2021. So that is one component, and actually typically the largest component of the RVU. You see here the new visit codes and then the new patient codes and the existing patient codes. New patient codes, the 99202 to 205, are changing by a small amount. But if you look at the RVUs for the existing patients, it is changing significantly, 28 to 46%. And this can be a big factor when it comes to payment in the future for us. Next slide, please. The RVUs, how are they used? So RVUs are used in payment calculations. There are other factors like the geographic practice cost indices and the conversion factor. And CMS comes up with a Medicare fee schedule based on these factors. It's the RVU times the GCPI times the conversion factor. So those 3 factors are used in calculating the fee schedule. Next slide, please. The conversion factor does typically change every year. This year, unfortunately, it's going to be decreasing by about 10%. CMS felt that this was necessary to obtain budget neutrality, they said. It had originally been decreased by, I think it was 11 or 12%, and then recently here in the last week or so, the final conversion factor came out as 3241, which, like I said, is about 10% less than it was for 2020. This decrease will affect all CPT codes, not just the office visit codes. So it's something to understand and pay attention to. Next slide, please. So how do all of these factors affect payment? So here is a chart, and this is some data from my EHR, PCC, and Chip Hart. He gave me the average for PCC clients as far as the percent of 99212s, 213s, 214s, and 215s. And what we did was we calculated using the work RVUs currently for 2021 and the work RVUs for 2020 versus 2021. And what we can see here is if we can maintain the same percent of coding that we've done before, 62% 213s, 30% 214s, there will be a significant increase in the payment per the 2021 Medicare fee schedule. You can see on the bottom line there, it goes from about 131,000 to about 155,000. So that is an increase of 18%. So that is a significant increase if our percent coding stays approximately the same. So that's even with the 10% decrease in the conversion factor. One thing to mention is that, again, this is based on 2021 Medicare fee schedule. Your contracts with insurance companies, your payment may be tied to a different year Medicare fee schedule or may not be tied to a Medicare fee schedule at all. But this is a common way that insurance companies use to decide physician fee schedules. Next slide, please. Changes to the administration codes, the vaccine admin codes. This is a little disappointing. The AAP has been advocating hard for us for several years on this issue. Since 2017, the RVUs for the vaccine admin codes has been decreasing. They had a proposed change to the admin codes, the AAP did, that would have increased the value of these as of January 1. Unfortunately, recently we found out within the last few days that this proposal was not accepted. Next slide, please. So this is what we were hoping for, that the admin RVUs would pretty much, well, almost double for a 90460 and would increase significantly for 90461. CMS has said that they will not decrease the payment for the vaccine admins in 2021. So we are uncertain exactly what this means. Since, like I said, the conversion factor is going to be decreasing by 10%, that would mean that the RVUs would have to increase. So at this point, this is still something that we are uncertain of, and we will continue to monitor, and the AAP will continue to advocate for us in the future. Again, this affects you if your vaccine admin payment is tied to a recent Medicare fee schedule. Next slide, please. All right, so my section's a lot shorter than John, so we'll have time for some questions. So my last thoughts on these RVU changes. Again, payment formulas that use previous Medicare fee schedules are not affected by the 2021 changes. So it's important for you to know your insurance contracts and possibly even your employment contracts. Some employment contracts are tied to work RVUs. And if that's the case, then with the significant increase in the office visit work RVUs, that could make a big difference in your compensation. Like I said, the AAP is continuing to advocate for higher RVUs for vaccine admins. There is a process that takes place for determining the RVUs. It starts at the AMA. The AAP have representatives on, it's called the RUC committee. It's a relative value update committee or something like that. And they present suggestions, recommendations to CMS to change these codes. So this is something that the AAP continues to look at. And we really do appreciate all of their advocacy for us on these issues. Next slide, please.
All right, thank you to both Mike and John. So we have some time for some questions. So I think what I'm going to do is, for those of you, some of you may be on a phone, can't see some of the chat. I'm going to kind of scroll through. We've been trying to answer some of the chat box questions, and I think we've answered everybody's, but I will kind of go through those in a minute. But first, before I do that, Jen Hardy in Cincinnati posted a question, and I'll let one of you take this. Kind of just talking about, she said, are you going to talk about billing based on time? And maybe even suggest framing that in that decision of when to consider using medical decision making versus when to bill on time.
Yeah, this is John. I can take that one.
Oh.
Yeah, the time, it would seem, most of the time is not going to be the way you'll bill. Here's the reason. The increments for the levels of E&M based on time, even though time is now defined in a much more expansive way, it, like a 99212 is, for an established patient, is defined in time as 10 through 19 minutes. And a 99213 for an established patient is 20 to 29 minutes. So in other words, if your otitis with a fever is somebody that you're seeing in and out, then you would get to your 99213 based on your medical decision making, and it would be hard to spend that much time on that visit. Now, that said, there are times, and you might come across it to some extent nearly every day, where something just takes an extraordinary amount of time. For instance, if you're reviewing voluminous outside records, or if you're having an extensive conversation with a parent, in other words, if you spent scads of time discussing something that ends up being basically a normal finding, say for a newborn, their umbilicus, or you have a very anxious parent or child, that will take a disproportionate amount of time. Or as others have said, hey, if your physical examination is an actual long physical struggle with a toddler, where you're scooting out wax and you can't charge a cerumen removal because they're not in primarily for cerumen impaction, they're in for their otitis, and their cerumen removal is incidental, so it's not a separate procedure, but yet it's time consuming. Or are you trying to make heads or tails out of an autistic patient where you'd have minimal cooperation for the physical, lots of time trying to figure out what's going on. All of those circumstances are ones where, now you have the opportunity to bill based on time. Now, how you address that in the documentation is important to note. I think it's not, luckily for us, we haven't gotten any guidance to make us think that you have to break down, how many times your eyes were on an external record, as opposed to how much time was spent, in person. The guidance we've gotten so far has been, you can just report the total time, but it would make sense to put something in your note to justify the length of time. And so in our institution, Nationwide Children's, we're going with saying that, hey, reviewed extensive records, or had or answered many questions, or needed much reassurance, something like that. Now, of course, as Chris said it right at the very beginning, this is all new territory. And I think it may be that payers are going to shape this conversation and put on their own restrictions on what you have to document for time. And if so, you'll have to go by those. You'll have to abide by those. But here's something important to know. There is something that payers will not be able to do. HIPAA, besides being about patient privacy, has to do with provisions for uniformity in how CPT codes are used. So in other words, the CPT code in 2021 means what the AMA says it means. So if Aetna is turning around and telling you, well, we're using the old system to evaluate your visit, and you didn't have enough history or physical in it, well, they can't do that. It's a HIPAA violation. The question is, well, the AAP is working on, well, who enforces, who's the HIPAA police in that instance? It's somebody, and I think the first denial or the first appeal letters that you write have to point out what the new descriptor is. Now, that said, payers do all kinds of things. Private payers, for instance, aren't bound by the CMS, relative value unit system, so they may choose their levels of payment and adjust them. But one thing they can't do is redefine CPT. You don't have to worry about CPT for 99213 means one thing for Aetna, but it means something else for Anthem. That's you won't have to learn 7 different rule books, in other words, for your CPT codes. So that's all on that subject.
Thanks, John. There's a question about, this is going to go into medical decision making. Does initiating a referral to a subspecialist, which would involve a referral form and sending office notes, do anything to increase the complexity and ultimately affect the level that you code at?
I'll open that one up. Certainly discussing with them does. Certainly, you would think that the need to refer might speak in many instances to the complexity of the problem that you're dealing with. Not certain that there's a provision in that, unless, of course, if making that referral and coordinating the care takes a substantial amount of time and you're billing on time. But I don't recall anything in our reports that talk about that as its own element of medical decision making.
Yeah, I agree with you, John. It's not specifically spelled out, but it may increase the amount of time that you're spending on the visit, or because of the problem that you're referring, the complexity or the risk associated with the problem might be significant enough to consider changing your coding or being a factor in your coding. But I don't believe there's anything specifically spelled out for referrals to specialists for an issue to increase the risk or change the MDM.
Great. Would one of you, one of the things that I do believe is increases the level that of your medical decision making is now taking into consideration the social determinants of health. And there was a question about using interpreters. Would this also count as social determinants impacting care? So if you would, maybe just a brief comment about social determinants and medical decision making, and if sort of language is really a social determinant of health.
It seems to has to impact your ability to diagnose and manage. And so I think not having an interpreter but needing one would certainly count. I think needing an interpreter and successfully diagnosing and managing, well, I guess you could say that you could make an argument to a payer saying that it increased the complexity to make the diagnosis or to manage, I suppose. One thing about an interpreter that we know is that an interpreter is not an independent historian. So that's not someone that you can count. Not that most of the time it's going to be the parent anyway. Using an interpreter where everything takes twice as long could certainly nudge you into having to code that encounter based on time, though. So that's an encounter lengthening event. So that's,
I think, yeah, definitely time. But also, John, in the oh, by the way, plug for the book, Coding for Pediatrics 2021 is my Bible, and I've literally been carrying it around everywhere I go for about the last 3 weeks. For moderate risk for MDM, diagnosis or treatment significantly limited by social determinants of health. So I wonder if even using an interpreter would qualify for a moderate risk. Again, I think a lot of this is not definitively spelled out, and it is, I think we will learn more and more over time. I know that the AAP is considering developing an audit tool that we can use and that maybe even insurance companies can use so that we know that we're following these rules appropriately.
And if I can jump in.
Oh, go ahead. I'm sorry.
Yeah. I noticed, since we're talking about interpreters and who is or isn't an historian, I noticed that some of the questions in the chat box had to do with identifying, a parent as a historian. One thing to note is that the parent does not have to be the primary historian. You don't have to worry about, well, who's giving me more of the history. I'm looking at the AMA guidance right here, and it says, an independent historian is an individual such as parent, guardian, so on, who provides a history in addition to a history provided by a patient who is unable to provide a complete or reliable history due to developmental stage or dementia, or because a confirmatory history is judged to be necessary. So, maybe the teenager is your primary historian, but if the parent has to say, no, you started having the cough 5 days ago, not yesterday, or vice versa, that person is still an independent historian.
Yep, absolutely. And how many times does that happen? All of the time when you're talking with teenagers, that you at least get part of the history from the parent or guardian or grandparent or whoever's in the room with you.
Right. Mm-hmm.
So speaking of time, there was a question about a lactation consultant that can we bill for time spent on lactation counseling at that first newborn office visit? And so I'll sort of let you address that, but also just kind of brings up the question of whose time can you consider when you're looking at time, right? Can you consider the time to check in a patient that your MA does? So if you guys wouldn't mind addressing that, that would be great.
Yeah. I guess I can take that one. So it's physician time. So if the physician is spending time counseling regarding lactation, then you definitely can use that time, or other qualified health professional. But as far as time from nursing staff or medical assistants or checking the patient in, or even work that could have been done by those, like if you check the patient in yourself as the physician, that should not count towards the time for coding, is the way I interpret it.
Right. And a related question is that I also saw in the chat box is who counts as somebody, a discussion with whom elevates your level? What counts as another external physician or other qualified healthcare professional? And the other qualified healthcare professional is an individual, according to the AMA guidance, who is not in the same group practice, or is in a different specialty or subspecialty. It might be in your same group practice. That includes licensed professionals that are practicing independently, but it may also be a facility or an organizational provider, such as a home healthcare agency, or a nursing facility, or a hospital. So all of those things count as where if you're engaging in a discussion with one of those, and it has to do with the management of the patient from that encounter, then that counts as a discussion, which is in that, if you remember, under data, that's one of the categories for the moderate and high levels of service.
I believe it was on a webinar yesterday, and I believe also if you're talking about ADHD or school problems, I believe teachers also can count as that as other professionals.
Definitely.
Speaking of ADHD,
yes, definitely.
There was I'm sorry, go ahead. There was speaking of ADHD, there was a question about, is a teacher Vanderbilt a second historian or an outside test result? And again, I think this was sort of addressed earlier, and gentlemen, correct me if I'm wrong, if you bill for that Vanderbilt, that does not count as an additional data point, right? So anything, a PHQ-9, a Vanderbilt, a Columbia Suicide, any of those things that you bill for, same thing with in-office tests, right? So as was mentioned earlier, an in-office strep test, an in-office hemoglobin or blood glucose that you do in the office and bill for does not count as an independent data point.
That's correct.
Correct.
In fact, the AMA has gone further and to say that it would be inappropriate to not bill for the Vanderbilt and include that instead in your medical decision making as a data point. In other words, they only, if you can bill it with its own CPT code, they want you to bill it that way.
Chris, can I say something about
of course
mental health visits, ADHD, because I've been thinking about this a lot. For MDM, we think about this a lot of times as time, and you may get to whatever code based on time, but the medical decision making for mental and behavioral health may work out in our favor. So if you have 2 or more stable chronic illnesses, you qualify for a level 4. And if you write a prescription, that's also a level 4. So that is an instant 99214 for 2 or more stable chronic illnesses. Or if you have 1 or more chronic illness with exacerbation, progression, or side effects of treatment. So I see this as sleep problems in kids with ADHD. I see this as anorexia, loss of appetite because of medicines. These are both side effects and maybe progression or exacerbation. Or if the problem's been going on long enough, that anorexia or sleep problem may be a second stable chronic illness. So I think proper documentation when it comes to our mental and behavioral health issues or visits can really possibly help us in this regard. So, because I know there were some questions about mental and behavioral health in the chat. So coding by time is fine, but also I think if we have proper documentation when it comes to how many chronic illnesses, whether it's an exacerbation or a side effect of treatment, that can help us in coding right there.
Thanks, Mike. I'm gonna sort of phrase this. There's been a couple different questions. One was a question about looking at coding a ill visit at the same time as a well visit, and really the question was the same rules apply, right? And I think this is really where now it actually benefits us, because you really couldn't double dip before, but now you're really just for leveling, you're either looking at really medical decision making, correct?
Or time, right? But I think it's simpler now that you use the same rules, whether it's a ill visit on its own or an ill visit with a well visit, that you either code by time you spent with that ill visit or the MDM for that ill visit. So they're just, in a way, 2 separate visits. The old rules, how you couldn't use the physical exam, really don't apply anymore. So to me, it's at least a little bit more straightforward than it used to be in the past.
And then there was a question comment about documentation, and says sounds like only HPI, PE, and assessment are needed. And so I'll sort of let you guys comment on that, but I'll just kind of say, I really now think of documentation as 2 separate things, right? So there's what you need to document to code at the level that you code at, which some of that's going to be based in your history, your physical exam, and your assessment and plan. And that's for billing. But then really, the rest of you still need to document to, let somebody know what happened, let your partners know, let, if obviously you were ever to be taken to court for anything, some documentation. And the other thing that I'll say for those of you that have medical students in residence in your office, we would have to essentially redo the history and physical exam for coding purposes, because especially for medical students, their HPI and physical exam would not count. Now for HPI, if a medical student writes an appropriate history that conveys all of the information that you feel is necessary for the care of that patient, you do not need to redocument that HPI, because it's no longer needed for billing and coding as long as it's accurate. Mike and John, I don't know if you have any other comments. We've got about 2 minutes left, just on sort of documentation.
Well, yes, I mean, documentation still needs to be important for caring for the patient first and foremost, and then for the possible malpractice issues down the road. But I think documentation in general is really important when it comes to medical decision making, and I think we will learn ways to phrases to use and things like that. Again, I'm going to plug the book, right? Because it's got phrases in here. I think if we use the same phrases that they use when they were coming up with these rules, I think will be that would be smart.
Yeah, I agree. I think that's right. I think for a lot of behavioral things, the new requirements mean that you don't have to worry about documenting, the physical examination at every visit if you were doing that in the first place, and you can just stick to what's pertinent. And some of the slides that we just very kind of that we passed over this time talks about how, gosh, some old templates for ankle sprain, have you try to specify which ligament you think was sprained, which of course is relevant if you're in sports medicine, but not if you're in primary care practice. And so, we're kind of liberated from those burdensome aspects of mouse clicking.
Great, Mike, any last-minute comments before we let everybody go?
I guess just use the AAP coding hotline when there are questions. They've been very busy here lately, and they're a little understaffed, but they are there to help us with these kind of issues. Another thing I'll plug is the section on administration and practice management. SOPM does a great job of sort of a roundtable discussion with their email listserv where you can ask questions to different people and see how they do things. So it's a great resource that I use.
Great. Well, I want to thank you both for sharing. Like I said, this is, we had one simple, learning objective, but obviously it turned out to not be quite so simple. It's very, very complex. We will send out the slides and sort of a Q&A as well as the recording of this podcast, and look forward in 2021 we will continue to do some education and publish in our Ohio AAP newsletter that comes out. So, and if you have questions, please reach out to the chapter, and hope you all have a great rest of the day, and good luck with implementing these in your practice. Have a great day, everybody.